My name is Melissa Waller. I'm an audiologist, and I work at MED-EL headquarters in Innsbruck, Austria. I have the pleasure of talking to you today about the topic of triformance. The word triformance for MED-EL means bringing the most natural hearing possible to our cochlear implant recipients. We have three ways of doing that, and I'd like to expand into what those three ways are throughout this presentation. Three unique characteristics leading MED-EL cochlear implant recipients to superior performance is the coding strategy that's used. This is called fine hearing in the MED-EL system. We aim to preserve cochlear structures with the insertion of the electrode array. We call this structure preservation, and we feel like this is very important, particularly for the pediatric population. And the last unique characteristic is complete cochlear coverage. Our aim is to take advantage of the entire cochlea and stimulate it from the apex all the way to the base. Let's explore some of these three topics in a little bit more detail. Structure preservation. In order to preserve the residual structures of the cochlea, it's very necessary to have a soft and a flexible electrode array. Electrode array should be lateral wall in design. And what we see is that even with deep insertions, even with electrodes that are 31 millimeters in length, we can preserve residual hearing. In this group of subjects, they either had the Flex 24 MED-EL array or the 31 millimeter electrode array. You can see preoperatively they all have residual hearing. Postoperatively, there has been a slight decrease in hearing by about 10 to 15 dB in the low frequencies. But nonetheless, the low frequency hearing remains, and it is measurable. So even by introducing an electrode array into the cochlea, it's possible to preserve the cochlear structures. Key to doing that is the electrode design. And what you can see here is we have a unique design, the zigzag wires, that are intended to make the electrode array much more flexible so that it is not able to deviate from one scala to the other. The intention of the electrode array is to be introduced into the scala tympani, and ideally that electrode array would follow the lateral wall of the cochlea and remain in the scala tympani. The alternative, a more traumatic situation, would be where the electrode array may enter the scala tympani, but it perforates the basilar membrane and ends up in the scala tympani. We see from multiple studies that have been published that in fact the patients who have this deviation perform poorer than those individuals that have a full scala tympani insertion. Now you may say, why is this important? Because most of your cochlear implant recipients don't have residual hearing. In fact, they have a severe to profound bilateral hearing impairment and may have little or no measurable hearing. Well, we believe it's important because the children that you're implanting today, at 1 year and 2 years old, will be living with this technology throughout their lifetime. And at some point, it may be that we have new technology. It may be a new cochlear implant that's a much better design, or it could be a pharmaceutical. It could be some sort of a drug therapy that encourages hair cell regeneration, and we wouldn't need a cochlear implant. We feel like by preserving this young cochlea, it offers the opportunity to take advantage of technologies and new innovations that may be occurring in 20, 30, 40 years, but definitely within the lifetime of these young users. A second component element of triformance is fine hearing. Fine hearing has to do with the coding strategy that we use in the system. Again, we're trying to provide the most natural sound quality to our cochlear implant users as possible. And I'd like to show you this study that actually compares the results of cochlear implant users to that of normal hearing individuals in a music study. Normal hearing individuals were given a variety of music samples, and these samples were cut in frequencies subsequently. In other words, the first sample of music was the full frequency spectrum, and then that sample was cut so that everything below 200 hertz was not available to the listener. There was another sample that was made where everything below 400 hertz was cut, and 600 and 800, all the way to the point where all frequencies below 1,500 hertz were removed from the music sample. Now, as normal hearing individuals asked to rate, how does this sound? This is what you would get. This is what our normal hearing subjects, how they score. You can see that in the uncut sample, the sound quality rating was very, very high. As the music samples were cut, as more frequency information was removed, you can see that the sound quality rating decreases. This is exactly what you would expect from a normal hearing individual. But what do cochlear implant recipients score? What does their performance look like? If they rated all of these music samples as very good, then that would mean that as we take information away, they're not experiencing that loss of information. Let's have a look at what the users of one coding strategy, high definition CIS, scored. In the green bars, you can see the CI users' performance using this particular coding strategy. Now, what's clear to you is that, as just like the normal hearing individuals, these subjects noticed a difference. As the recording had more and more frequency information removed from it, the sound quality rating went down. But you can see not as much as with normal hearing. It means that the cochlear implant users are experiencing a decrease in sound quality, but not as dramatically. Now, if we could get them, our CI users, to look a bit more like normal hearing, we'd be getting closer to more natural hearing. Let's have a look at the results with a cochlear implant group using the fine hearing coding strategy. And you see those results here in the red, the lighter red actually. What we immediately notice is that the lighter red bars more closely follow what the normal hearing individuals scored. As we remove frequency information, the CI users using fine structure processing appreciate more of a decrease in that sound quality. I think what that means is that the fine structure strategy is doing a really good job at bringing more natural sound quality to these users. The last element of triformance I'd like to go into is complete cochlear coverage. Our aim is to stimulate the entire cochlea from the base to the apex. That in turn gives us better place pitch matching, and that ultimately ends up in a complete spectrum of sound for more natural sound quality. We learned a lot from electric acoustic stimulation users. These are individuals who have audiograms similar to the one that you see here, where we have excellent low frequency residual hearing, and we have a significant decrease in high frequency hearing. In other words, a severe to profound hearing loss in the high frequencies. In this group of subjects, we address the high frequency loss with electrical stimulation. We address the low frequency loss with amplification. And we see that when we combine the electric and the acoustic stimulation together, the patient's performance drastically improves. Let's have a look at that. Here what you see in the red bars is the individuals who were stimulated electrically but were not stimulated acoustically in the apical region where they had the residual hearing. And these results occur over time at 3, 6, and 12 months. When the hearing aid component of the system was put in place, in other words, the apex was allowed to participate in the evaluation. You see a dramatic improvement of almost 25% between electric only and electric acoustic. What this tells me is that once we once we allow the apical region to be part of the test, the patient's performance improves dramatically. So this holds true for EAS users, but does it hold true also for our standard cochlear implant users? And there was a group at the University of North Carolina who studied this question, and they looked at the influence of cochlear implant insertion depth on performance. They had two groups of individuals that were very much identical preoperatively in terms of the amount of residual hearing, etiologies, length of deafness, etc. One group was implanted with a shorter array. This would be a 24 millimeter Med-El electrode array. It's what we call the medium. And the other group was implanted with a standard array, which is 31 millimeters in length. Now, what that means in terms of how much of the cochlea is covered is the medium group had on average 423 degrees insertion angle, so that's a bit more than one full turn of the cochlea. On the other hand, the standard array group had 657 degree on average insertion angle. That means about 230 degrees of the cochlea in the standard array group was stimulated as opposed to the medium group. So we have a deeper insertion with the standard array group. How does that impact performance? Well, in this slide you can see the blue dots are the standard array group and the red squares are the medium group. We're looking at their performance on a sentence test. This is HINT, sentences in noise, and the noise is a plus 10 dB signal to noise ratio. This makes the test fairly complicated. The dotted lines, blue and red, are the average performance of the standard group and the medium group. Along the bottom, we see time. So this is the results through the course of the first year of implantation. And what we see is that the standard electrode array group outperforms the medium group at all test sessions along the timeline. And at 12 months, we still have a performance difference of about 12 or 13% between the two groups, with the standard array performing better. Now remember, it's the standard array that has the deeper insertion, has more of the cochlea covered. The question that the team asked at this point was, does this difference hold true over time? In other words, at 2 years, are we still seeing a difference between the groups, or is it possible that the group with the medium electrode array continues to improve and catches up with the standard array? And we now have very recently published 2-year data that shows, in fact, the medium group is not catching up. We still have a performance difference between the two groups, with a longer array creating better performance, more of the cochlea coverage in this group of individuals. The three components of triformance leading to the strength of the system and the superior performance of our users is the coding strategy. The coding strategy is designed to mimic as closely as we technologically can that of the normal auditory system. When stimulating the cochlea, we want to do this in a very atraumatic way. We believe that the children that are implanted today will be living their lifetime with some sort of technology. The more we can preserve the cochlea at this time, the better we increase their chances of successful use of different technologies. And we are able to stimulate the apical region. We're able to reach the apical region with a long electrode array. We're able to stimulate it without causing any trauma. And in doing so, we bring better performance. And after all, as audiologists, that's what we would really like to see with our cochlear implant users, the very best performance possible. Thank you very much for your attention.